All right. So good afternoon once again, and first of all, I would like to thank our Chief Instructor, Dr. Rajiv Reddy, for making me a part of this instruction course and also for teaching most of us the nuances of endoscopic vitrectomy. And also I would like to thank the AIOS Scientific Committee for giving us a chance to present this work. So I'll be speaking predominantly on diagnostic endoscopy as to how endoscopy can be a valuable tool in prognosticating these eyes. So if you look at these eyes, these are eyes of failed graft, corneal scars, post-keratoprosthesis, where sometimes prognostication is difficult. How do we go around treating them? Should we go with a repeat graft or can we leave these eyes like that? And if you look at it, a lot of times while the B scan may help us in assessing the fact that the retina is attached or detached, it does not give us much of a knowledge about the structural integrity of the retina, how the retina is, how the disc is. So those are some of the parameters which a B scan will not be able to reveal. And that is where a diagnostic endoscopy comes into picture. Dr. Puneet had earlier shown in his talk a case where post-trauma they had gone ahead and done a diagnostic endoscopy and visualized the retina. So this is how a diagnostic endoscopy setup helps us. What it helps us is it allows us to assess the retina as well as the optic disc and can help in a better prognostication in these cases where a conventional ultrasound probably may not be much helpful. So these were some of the other images. This is the patient with a corneal scar, while a B scan does reveal an attached retina. If you look inside, you go and see an absolutely glaucomatous optic disc with sclerosed vessels. This is not an eye which is likely to benefit from any further intervention. Same holds true the next case, a case with a keratoprosthesis, where while we do see a detached retina, you may think that we can go ahead, probably do a repair, but an endoscopy allows us to visualize the fact that it's an extensively necrotic retina, where it will not probably yield a much of a visual prognosis. Another case with a failed graft where we see a retinal detachment, and an endoscopy gives us a visualization where we can see it's a closed funnel RD with extensive membranes. Again, a case for a poor prognosis. So these are cases where endoscopy allows us in prognostication. So thereby, by allowing us to prognosticate, it can help us in a more judicious use of these corneal allografts and more judicial use of a corneal reconstructive procedure subsequently. So if you look at it, this is how the endoscopy system is. This is the E2 laser endoscopy system by Endo Optics. It allows us, unlike a conventional vitrectomy which gives us an end-on view, over here, a diagnostic endoscopy gives us an end-on view, unlike a conventional which gives us a bird's eye view. So what you see over here is this is your endoscope camera, and this is the area which you can subsequently visualize. My slides are stuck somehow. So let me just show you how an endoscopy works over here. So this was one patient with an opaque graft, but when we went inside, we could visualize the fact that the retina was attached and the disc was healthy, and this was a patient where we could subsequently go ahead and do a repeat surgery. Same holds true for this eye. Once we did an endoscopy, we were able to visualize the retina, which was absolutely healthy, and a good healthy disc. So these are cases where a diagnostic endoscopy allows us to visualize the structures which are not clearly visible. This is a video courtesy my co-author of and co-instructor in this course, Dr. Vivek Dave. And endoscope also allows us, apart from that, to visualize angle structures and in some cases an occult foreign body which may be stuck. So these are some of the advantages which an endoscope affords us, allowing us to visualize areas which were till now not accessible or amenable to a conventional visualization system. So this was a foreign body stuck in the angles, and with the help of an endoscope, Dr. Vivek Dave was able to visualize it and also helped in its removal subsequently. So these are some other cases where an endoscopy allows us visualization of ciliary bodies, allows us to visualize membranes and do a PVD and complete surgery. Membrane peelings can be done. Peripheral retinal detachments can be assessed over here in these cases. So peripheral retina detachments, peripheral breaks, all of these can be assessed with the help of an endoscope. And this is something which we have tried to initiate. We tried to start having a form where all the surgeons who did an endoscopy could document the data regarding the structures which were visualized, including the angle structure, ciliary body, posterior surface of iris, and posterior segment findings. So we did also analyze these results and found out in a paper which we had published the fact that an endoscopy allows us to visualize these areas, and these were the indications, penetrating trauma being the most common one, and pale disc and sclerosed vessels were commonly analyzed. Apart from that, advanced glaucomatous cupping, scarring in a few of cases, retinal scarring, hemorrhages, and choroidal detachments were the findings which we assessed with the help of these. in all of these cases. In fact, when we tried to compare with an ultrasound, we found that an ultrasound was able to pick up it in 23 cases, but there was one false positive. And there were 3 cases where there were false negative on an ultrasound. So endoscopy helps us in better assessment of these structural abnormalities, which probably we might miss with conventional ultrasound. And thus I would like to just conclude by saying that it also helps us in better utilization of further corneal reconstructive procedures and in allowing us to visualize these structures. And with that, I would like to end my talk and thank you once again for a patient hearing.
Thanks, Mudit. Any questions? If not, I'll have one.
Tell us about the learning curve.
Yeah.
Because it's so different from regular vitrectomy. When we see, under the microscope, the learning curve, I'm worried about how long it takes and to be a good endoscopic to do it well, what do you have to do to?
Yeah, so like I said, what we do in a conventional vitrectomy system is we've got a bird's eye view where you can look from above and you can see the visualized structures. And endoscopic surgery has got an end-on view. So it takes an initial learning curve. You may probably need at least 5, 6, maybe more surgeries. But the important point is like what our earlier instructors had told about, Dr. Rajiv had said, Dr. Puneet has mentioned, and probably Vivek also will be talking in his talks about the fact you need to, once you get the hang of how to insert your instruments and how to follow your instruments once your probe is there, and to follow up the cutter and visualize it, then over a period of time you do get a hang of it. So while there is an initial learning curve which is involved, it is not a difficult skill otherwise once you get the hang of it. And it becomes extremely valuable in management of your cases.
The best way to learn endoscopy initially is to use your endoscopic view endoscope in your normal routine vitreous surgery also. You can use your endoscope for illumination, and simultaneously you can view structures in front of you on the screen, but you can perform surgery through endoscope. So initially you get hang of it, how things are visualized with the endoscope. So that is the way I started.
Yeah, while Vivek is setting up, I'll comment on that. So when I started, the first surgery I did was with endoscopy to do a surgery straight away. So I could manage to settle the retina without having a problem. So having said that, it's not going to be easy. That's the first surgery. Like you can say that it's a beginner's luck, but it did take a long time for me to be little safe, I would say. So what I did was I used to like what Puneet was talking about, maybe use it along with where the visualization is good. And 2 is I used to do a diagnostic endoscopy. That's how we published that paper first. Whenever we are planning to do a keratoprosthesis, which is going to be an extensive procedure, we started doing a diagnostic endoscopy and then started going ahead doing that procedure only if there is a good visual potential in that. So that got me used to it. So that gave us another question which we wanted to answer. How about the learning curve which you were talking about? So Vivek actually had to look at different videos which we have recorded over a period of time and see what the learning curve is going to be. So he would be in a better position
if
to answer
time permits,
that.
I will show you a graph.
Okay.